Hello, everybody. All right, so we're going to get started. Welcome to We Can't Go Back, Sustaining MAT Access After COVID. This discussion is co-hosted by Sonoran Prevention Works, University of Arizona's Mel and Enid Zuckerman College of Public Health, and University of Arizona's Southwest Institute for Research on Women. I'm Haley Coles. I'm the Executive Director at Sonoran Prevention Works and super grateful for the turnout. Really glad you all are here and interested in these really important conversations that we're having. So for anybody not familiar with Sonoran Prevention Works, we are a peer-run statewide harm reduction organization focused on improving the health of people who use drugs from the micro to the macro. So our outreach workers, they're located in Yuma, Pima, Maricopa, Yavapai, and Mojave counties. And they reach some of the most marginalized individuals in their communities through distribution of naloxone, fentanyl test strips, wound care supplies, food, and other resources to improve health and safety. They conduct HIV and hepatitis C testing and linkage to care, and also provide peer support services to individuals at all stages of the substance use continuum. Our overdose prevention coordinators provide training and technical assistance to organizations across the state to support institutional implementation of overdose prevention tactics, including distributing over 460,000 doses of naloxone, with over 12,000 overdose reversals reported to us since 2017. We also run the only syringe service program in Northwestern Arizona, which is the Kingman Harm Reduction Program. And we work at the city, county, and state level to increase awareness of policies that impact the health of people who use drugs. So lots of partners help us do what we do. We are eternally grateful for them. So now we'll jump into the presentation. As many of you know, the COVID-19 pandemic has created immense hardships for our nation, as well as opportunities to critically think about long-standing norms and assumptions. Federal and state agencies have enacted rapid changes to keep people safe, such as instituting eviction moratoriums, expanding unemployment benefits, and of course, what we're discussing today, loosening restrictions around medications for opioid use disorder, which have been historically hyper-regulated. Our speakers today will discuss what we know so far about the regulatory changes and the need for continued research, the successes and challenges of implementation from the perspective of an OBOT, which is office-based opioid treatment program, mostly focused on methadone in this discussion, an OTP, opioid treatment program, which is generally buprenorphine, the unique perspective of treatment changes in Indian country, and most importantly, the direct impacts on patients from a patient's point of view. Our speakers will take turns presenting, and then we'll have time for Q&A at the end. Drop any questions in the chat that you'd like us to answer during the discussion portion. And this discussion is being recorded and will be posted on our website later this week. And we'll send out the link to everybody. So we're going to start with our first presenter, Dr. Beth Meyerson. In 2019, Dr. Meyerson joined the faculty of the University of Arizona as a research professor. She's affiliated with the Southwest Institute for Research on Women, CIRO, in the College of Social and Behavioral Sciences, with Family and Community Medicine in the College of Medicine, and with U of A's Institute for LGBT Studies. Prior to U of A, Dr. Meyerson was a bicentennial professor of health policy and management at the Indiana University School of Public Health Bloomington, and the co-director of the Rural Center for AIDS and STD Research with affiliation at the Kinsey Institute. Beth has 3 decades of public health practice and research experience, typified by roles as president of a policy research consultancy focused on HIV and sexually transmitted diseases with an international portfolio, as the state AIDS STD director for the state of Missouri, and directing a nonprofit AIDS service organization. Dr. Meyerson's research interests include public health policy and systems to advance population health with focus on sexual health and harm reduction. Her research is oriented as translational to program and policy through the application of implementation science and community-based participatory and action research. In Arizona, Beth works with several nonprofit, foundation, and government partners to advance community health through structural means of policy and systems. To get more of a flavor of her work in Indiana, please refer to her TED Talk, The Art of the Small, given following Indiana's HIV outbreak among people who inject drugs. So now, welcome, Dr. Meyerson, and let me know when you want me to change the slides.
Great, thank you. Oh, I'm thrilled to be here with everyone. You can change the slide, Haley. Thank you very much. I'm going to try to get this fairly fast so that we can focus together on conversation. We're going to talk about the changes under COVID-19, the evidence so far, and especially around diversion, and additional policy issues for attention. Please, next slide. So where we are right now is that racism and penal thinking, carceral thinking has been baked into the way in which we practice treatment and access of care. And we're also facing a situation where any policy change will have to contend with the challenges we've had to address in terms of evidence for some time, and that includes diversion, and I'll spend a little bit of time about that. But what we know is that, and important to know here, is that despite their own evidence, and this is DEA's evidence around diversion, DEA continues to view diverted methadone as a public health threat in terms of overdose, and a public safety threat in terms of street methadone, if you will, and a barrier to OUD treatment. But what we know is that that isn't necessarily the case. Next slide, please. So I'm going to first talk about relevant policy issues in the US. There are a few diversion studies here. The problem is a measurement problem. So all the analyses collapse methadone treatment with other drugs and also methadone prescribed as pain medication. And so the Institute of Medicine, IOM, this is part of the National Academies of Science, has it basically indicated that this is neither a public safety nor a public health problem in terms of methadone diversion. And that we've seen, even with all the combined issues with measurement, diversion has declined due to clinical practice guidelines and monitoring. This is specifically around OBATs, or those who prescribe methadone out of their offices. Next slide, please. What I would suggest to you also in terms of diversion here is that if we see diversion, or when we see diverted methadone and buprenorphine, it's as we might expect. It's because of treatment access issues, missed methadone pickups, or people trying to help someone else relative to staying well and not dope sick. So these are good studies. The Johnson study, the Shulman-Oliver study, and the Duffy study are probably the best we can get to relative to diverted methadone or buprenorphine that is not combined with other drugs, that is not combined with methadone as pain medication. Next slide, please. So when we talk about the temporarily allowed policies by the federal government, this is CMS, DEA, SAMHSA, they regulate these substances in our country. There are several, and they're relevant to certain settings. OTPs, as Haley noted, these are methadone clinics. OBATs are office-based opioid treatment providers. This is a list of most of the key temporarily allowed COVID policy changes. And really, the essence of this was to assure access and reduce exposure to COVID. Next slide, please. And again, we don't know that these are the policy benefits. This was the spirit of these policies, that they wanted certainly to reduce clinic-based COVID-19 exposures for patients and staff. I think as a person that works in this space, my hope about it would be that we actually move further and reduce the life work disruption for methadone clinic patients. A colleague of mine, Dr. Benjamin Brady from the College of Public Health here at University of Arizona, led a study which found essentially that Arizona drive time to methadone clinics is 50% higher than office-based opioid treatment providers, and this is across urban and rural settings. And in the most rural, there were no methadone treatment providers. And so I know Nick will probably talk about those kinds of policy issues as well, state limitations on who can provide methadone, et cetera. Next slide, please. So when we talk about the impact of these temporary policies, we really have to ask two types of questions. The first bucket is implementation. The second bucket is outcome. And so when we put together evidence for policy influence or policy information, we have to be thinking about these things. Who's implementing these temporary policies and where? And it's not just about methadone treatment and OBOTs, it's all about the types of clinics, because opioid office-based treatment for with buprenorphine, for example, might be in an FQHC or another kind of doctor's office or a community clinic of some other kind, et cetera. And so we have to understand those settings, where they're implemented by whom. How are these policies being implemented? Are they in full? Are they fully being implemented? All of them? Are only certain patients actually getting these opportunities, et cetera? And then we look at also multi-level factors that influence or predict the implementation, and I'll share with you what I mean by that in a moment. Finally, then we get to look at, well, okay, once we know the Rube Goldberg of implementation, what is the impact of the implementation on access to treatment, patient health and recovery, and how do patients experience this time and these changes? Next slide, please. So the thing to be thinking about is just how complex this is. And we can break this down. In fact, our team has done so by developing a mood access policy implementation index. And this helps us measure the varying implementation around policies and setting, around the degree of implementation in terms of all your patients, some of your patients, new patients, et cetera. Next slide, please. And when we talk about the complexity here, if you just, yeah, there you go. Here are the multi-level factors. So think about all the things that could affect the way providers decide to implement something. There are pressures from the outer setting, policy pressures, what they're allowed to do and what they're not allowed to do, patient needs and resources. Can the patients actually access telehealth, for example? What's the impact of COVID locally? Do they have state policies that are shutting them down? There are inner setting characteristics that matter in terms of the implementation climate. Are they part of a practice that tries new things, that are ready for change, that have some kind of social receptivity among the peers of implementers within the clinic? This isn't even about the patient yet, so you can start to see the complexity here. And then there are intervention characteristics themselves. That means in this case, about the policies. Which policies have strength and quality of evidence? What are hard or complex to implement, etc. What they believe about relative advantage to their patients, and then individual characteristics of the providers themselves. Next slide, please. So what do we know so far? There are very few studies and they are small. So not a lot of really what I would call robust evidence. There are a couple, at least 2 Arizona-based preliminary studies. Ours is one of them. All of them are convenient sampling. That's a problem that we want to solve. There was a study by RAND among 13 states, 20 providers in 13 states. And from all of our studies, the key findings are that everyone is implementing this differently. This should be nothing new to you, but just so you know. So this is really complex in terms of understanding the impact on people and treatment. That many increased multi-day dosing, but not for all patients. They went to monthly injectables from methadone in some cases. In some cases, they increased telemedicine use. There were costs and time to ramp up and run telemedicine. And that almost 50% of these mood providers that were in our small studies collectively stopped taking new patients for many months under COVID. And some of that was to prepare for the safety protocols. Others opened up even further because they knew the problem, and that there were mixed opinions among these providers about continuing policy implementation after the feds might remove their temporary allowances. So what I'm showing you now is not a lot of strong evidence, which should tell us we need to get better evidence. These will take more robust studies. Next slide, please. So there are additional things though at play, and these are the state policy arenas that can affect whether providers can even implement and implement well or fully what the feds are allowing. And the ones in bold are the ones that I want in Arizona's focus, because Arizona needs to focus on them further. And Nick may have some other thoughts, and Christina too, and you might hear about that. Part of that is parity to incentivize telemedicine. If you're paid more for seeing a patient in person, you might not likely do that. And in fact, patients have indicated to me some problems where they have to come into the clinic only to be shepherded into a room to meet with their provider by video. But the clinic itself can bill for face-to-face. So there's some important kinds of risks that are undertaken that we need to understand that are policy created. We need to suspend counseling requirements that limit medication access. There are other states that need to remove caps for number of OTPs, et cetera. So these are the kinds of things that are at play, not just federal level policies, but state too. Next slide, please. I guess that's my last slide, which probably just as well with 17 seconds. So I look forward to the conversation with you all, and hope that you'll have some questions about policy that we can answer. Thank you.
Thank you, Beth. So our next presenter is Nick Stavros. Nick is the CEO of Community Medical Services, where he has worked for the past 8 years. Prior to his tenure at CMS, Nick served for 8 years in the U.S. Army as an intelligence sergeant and airborne ranger qualified infantry officer, and went on to receive his MBA from UCLA before becoming the CEO at CMS. Nick is the Arizona representative to the American Association of Treatment of Opioid Dependence, which is ATOD. Community Medical Services offers opioid treatment, OTP, and OBOT services through 44 centers across 9 states, with the vision to eliminate the consequences of substance use disorders in our communities. So Nick, take it away.
All right, thanks, Haley. Can everybody hear me okay? Okay, cool. So yeah, thanks so much. I'm going to, I think hopefully I won't cover anything that's redundant with what Beth just covered, but it'll hopefully add kind of upon it. We have programs, we have about 44 programs in 9 different states. And so I think this could be an interesting conversation because we've seen a whole array of regulatory changes. Different states have done different things and it's had different impacts. And so, you know, like Beth alluded to, we're still trying to make sense of all the data and what actually happened. But so bear with me here. I'll show some data. I'm first going to start talking about kind of a bit of the projections that were that came about over the last couple of years in regards to the opioid crisis prior to COVID, and then we're going to take a quick look at what actually is happening. And so, you know, I like to talk about this quote on this slide a lot. Don't let perfect be the enemy of good. You all have probably seen that at some point. It's from Voltaire. And I think it applies here. It's you know, I think it actually applies directly to, you know, harm reduction and how we think about harm reduction, and, you know, and the idea that incremental changes are sometimes, if that's the best we could do at times, then it's better than not doing them. And so we'll talk, I'll talk through these slides about some of those changes that we'd like to see, but I'll probably refer back to that quote a few times. So next slide, please. So this is a model I've actually presented on this study a few times in the past. This because it came out in 2019 by Mass Gen Hospital, looking at what was going to happen over the next couple years with the opioid crisis based on current interventions. So the model projected 147% increase in overdose deaths by 2025, and it said that current interventions will only have about a 3% impact on that trend. So this is 2019. This is before, actually it was looking at data from a couple prior years. And so this is before anybody knew about COVID. This model came out saying, hey, red flag, the current interventions are only gonna have about a 3% impact on the current overdose death rates caused by opioids. So next slide. There's a lot of things I could talk about from that model and from the study, but I'm just going to focus on a few. One of the interventions that they said would contribute to increasing overdoses is cracking down on prescribing by doctors. We've all kind of been told the narrative that we're in the midst of an opioid crisis because of doctors overprescribing. We all know that there's a lot more to the story than that. We're in the midst of a multi-decade drug epidemic, not just opioid, and it just so happens that this phase right now is the opioid phase. And so as you could see, when we start cracking down on prescribing, then the supply chain kicks in, and we start seeing, you know, things like fentanyl, you know, cheaper drugs making their way onto the street. And so cracking down on prescribing tends to a lot of times have inverse impacts. And so let's go on to the next slide. Another data point from that study The study said if there is a recession in the next few years, which, we're bound to have a recession at some point, you're going to see an increase in overdose deaths. And it really focused on looking at what happened in 2008 with the recession in 2008. What impact did that have on the opioid crisis? They found that for every 1% unemployment rate increase, you see a 3.6% opioid death rate increase and a 7% increase in ED visits. So just keep in mind, this was all pre-COVID, kind of warning what was going to happen, not even knowing about COVID. So on to the next slide. That's pre-COVID. Let's talk about what happened during COVID. So next slide again. I got to get through a lot of slides in a short amount of time, so I'll race through these, and then I'm happy to discuss anything during the Q&A afterwards. The immediate effects of COVID on treatment. So early decrease in drug precursor chemicals produced in China. I don't think this is a surprise to anybody on this call. Decrease in supply of drugs coming into the US from Mexico. Cessation of many self-support groups. Closing of inpatient treatment programs. Increase in stressors, job loss, social isolation. Closing of harm reduction programs throughout the country, and in particular syringe access service programs. And we know, people attending syringe access programs are 5 times more likely to get into treatment. And then decrease in media attention to SUD, and that is a huge one. The COVID discussion has taken the narrative to such an extent that a lot of people are not even talking about the opioid crisis while it's growing worse and worse and worse, as we can see on the next slide. So here's you see the declaration of COVID-19 national emergency right there in March. You see just overdose death rates or positivity rates, which most likely correlates with overdose death rates, just skyrocketing. Fentanyl has obviously taken the lead there. And, I don't think that's a huge surprise. I know we saw similar trends in our clinics when stay-at-home orders were put in place. People were less inclined to seek treatment. Social isolation was really starting to kick in. And so next slide. So you'll see the impact that it actually had on treatment organizations. 54% of organizations ended up closing their programs, and 65% had to cancel, reschedule, or turn patients away. So that's kind of an overview of what's happening industry-wide. But the next couple slides, I'm going to talk about some specific data from our organization. So next slide. So this is internal data. So next slide again, sorry. This is from our organization, CMS. We have about 16,000 patients in treatment. Let's go through these slides, then you could draw some correlations in your head, but we could, because I'm not necessarily talking about correlations at this point, I'm talking more about just data trends. But when we get in the Q&A, we could talk about correlations if anybody sees anything interesting. So just briefly, top left is behavioral health interactions. The orange is in person and blue is tele. So as you can see here, the percent change, we made a big pivot to telebehavioral health. And in today, in November, it's about 50, 50-50, it fluctuates, in-person behavioral health versus telebehavioral health. And then same on the medical side, which is the graph to the right. I don't foresee that changing in the future. We did a lot of telehealth prior to COVID, as you can see there, 20% on the behavioral health, 30% on the physical health. But we see this pivot continuing into the future. Now, if you look at intakes since COVID, you see a big dip in April. We were doing about 1,000 a month intakes across the board. That dipped to about 776 in April. And that's kind of with the stay-at-home orders, people stopped seeking out treatment. Now that's climbed back up. We've also opened additional clinics. The numbers at the end, don't mind those because this is to date, and so it might only include a portion of a month. But bottom right is daily in-clinic patient volume. So as you all know, patients in an OTP who are particularly on methadone typically have to come in, a large number, usually maybe 50% of our patients are coming in daily pre-COVID. And so as you can see here, we had a huge decrease in April, March, April of people coming in the clinic daily. So out of 16,000 patients, we had about 3,700 coming in daily. So the vast majority of our patients moved to some other phase level in the clinic. And then as COVID, as the kind of pandemic continued, we saw people coming back into the clinics. And I'll talk about that on the next slide. So these are the extended exceptions, and we'll talk about this a little bit today, but extended exceptions mean if somebody is on, let's say, daily privileges, they have to come in daily. In states where we were allowed to move people to, say, weekly or bi-weekly or tri-weekly, whatever, that means they're on an extended exception. So an extended exception in the face of COVID. So as you can see, in places like Alaska, where it's hard to travel, distances are far, that's the blue line on the left, it looks like about 42% of our patients were put on extended exceptions. And we obviously had a lot of criteria. If somebody was consistently testing positive for fentanyl, that would be a red flag where we'd be less inclined to put them on the extended exceptions. If you follow along what happened with COVID, you could see that decreased over time. The interesting thing here is Wisconsin is that gray line on the bottom. Now, the reason it's upside down is because we actually opened more clinics and took in new patients, which made it below zero. But it still tells a story, and that story is Wisconsin's one of the only states we were in that actually really cracked down on take-home on exceptions. And after like 2 months, the state basically stepped in and said, you can't do this anymore. You can't give extended exceptions. A lot of states like Arizona were a lot more, gave a lot more autonomy to the clinics to make the decisions. But places like Wisconsin, I mean, they really took away that ability. And so that's why you see that kind of upside down bar. And we'll talk about this more in Q&A too, but we did see, actually go on the next slide if you could. We did see some negative outcomes with COVID, with the extended exceptions. Once we gave extended exceptions, you can see the top graph here, and we have our own lab for a lot of our clinics, and so we actually have access, like direct access to our lab data, which is pretty cool. But you see in the March timeframe that with extended exceptions, you do see a decrease in compliance. That's the top graph is compliant to their medication, meaning they're taking, if they're prescribed methadone, buprenorphine, or naltrexone, they're actually taking it. That's compliance. And then percent abnormal on the bottom is if they're testing positive for any illicit substances. So over the COVID period, we saw I haven't figured this out yet, but we have seen an increase in compliance over time and an accompanying increase in illicit use. And so that's interesting. I don't know what to make of it, but the March drop right there is really interesting. When people went on extended exceptions, we started seeing less compliance, and so and presumably more diverted methadone, which is hard. It's hard to measure because a lot of times it's hearsay. Somebody will say this patient diverted their methadone. If somebody's on 2 weeks of take homes, it's not always easy to tell. So we're trying to still make sense of the data, but a lot of people. A lot of our patients did come back in the clinic and say, I actually appreciate the accountability of coming and seeing, meeting with my counselor on a regular basis, and they actually had worse outcomes with COVID and extended exceptions. And we saw the opposite. I mean, in some states like Montana in particular, we heard a lot of patients say, I do much better when I don't have to come in the clinic as frequently. When I could make my counseling appointments on my own time and take a walk when I'm doing my counseling and stuff like that, it was, I think it's really geographically specific, and we haven't yet figured that out. So next few slides, I'm almost done here. Okay, that's positive UA results. As you can see, there was a spike in fentanyl. Now we know that there was a spike in fentanyl in Arizona because it moved kind of from east to west, and so that might not accompany COVID, but we did see a steady increase in positive fentanyl for our patients. So skip 2 slides forward. One more. Okay, here's the treatment gap. So here's what I'm saying needs to happen. We have far too few people in treatment. There's studies that say maybe 15 million Americans have a substance use disorder that has not been diagnosed, or an opioid use disorder. They might be receiving long-term opioid pain relievers for chronic pain. They might have an undiagnosed addiction. But what we know is that far less people are getting into treatment that need treatment, and far fewer OTPs in particular, the only type of agency that could do methadone, exist in relation to what's needed. So the question is why? I think we all know the answer. The answer is stigma. Stigma is the #1 reason that prevents people from getting into treatment. Next slide, please. And to kind of touch on something Beth mentioned, diverted methadone, the DEA has said consistently methadone is being diverted from pain management clinics. This graph tells that story. As you see an increase in prescribing for methadone for pain management, you see an increase in overdose death rates for methadone. Methadone is, the research says methadone works for more people than buprenorphine. So more people respond to methadone than they do to buprenorphine. However, methadone is also much, much more dangerous than buprenorphine. And so that's you know, that's a juggling act. How do you expand access to treatment, but not further contribute to the stigma against MOUD by having, you know, increased overdose death rates? And so unfortunately, a lot of times you'll see on the front page of the newspaper, you know, patient on methadone gets in car accident and kills somebody. But when you look at the coroner report, they had, you know, 5 other drugs in their system and they were, you know, suicidal or whatever, but the methadone gets blamed. And that is, you know, it really does come down to the stigma against addiction. Next slide, 2 more slides, almost done. I know I'm falling behind here. This is the only study that I've seen that actually compares, you know, in Canada, the OTPs in Canada are basically doctor's offices with pharmacies attached. And so a patient does not have to go from the clinic to a pharmacy to pick up the medication. What they found is there's a substantially higher retention rate when patients receive their medication on site than if they go off site to a pharmacy to pick it up. And so that's something that, as we kind of look at the model in the US and any changes that could be made, keeping that in mind. And then last slide here, not too much to talk about. It's just, it's from that original study on the first slide. It shows you really what our priorities as a country are. You know, 760,000 electric car owners in the US compared to 4 to 6, up to 15 million people suffering from an opioid use disorder, yet $2 billion has been invested by our government for electric cars, $1 billion towards opioids. You know, you could go through this and just see that there is a lot less focus on something that's killing a lot more of our you know, friends and family, yet not getting the attention it deserves. And so that's why I think we're all here today. That's what we want to talk more about, is not losing sight of this fight, because it's so far we are losing the fight. And that is it. Thank you very much.
Thank you so much, Nick. All right, our next speaker is Dr. Christina Arredondo. She currently resides in her hometown of Tucson, where she is raising her family amongst an extensive family unit. She has traveled throughout the United States and beyond for both pleasure and education. After graduating from Carleton College in Northfield, Minnesota with a BA in psychology, she worked in mental health treatment and research in San Francisco and at Stanford University in Palo Alto, California. Dr. Arredondo completed her medical training at University of Washington in Seattle, and then psychiatry residency and public psychiatry fellowship at Yale University. Currently, she is board certified in psychiatry, addiction medicine, and public psychiatry. Since that time, she has worked in both inpatient care, outpatient care, and emergency care, and in both the private and public sector. Her interests lie in capacity building in public health, native health, data management and surveillance, addiction services, integration of culture into a medical model of care, and helping bring about behavioral change. She is the past medical director at the Pasquayaqui Tribe Health Services Division, and currently the medical director of behavioral health at El Rio, while continuing her work at the Pasquayaqui Tribe MAT program. In addition, she is on the board of the Pima County Medical Society, teaches medical students at the University of Arizona student-run Mind Psychiatry Clinic for uninsured patients, precepting for psychiatry residents and addiction fellows at the University of Arizona, and hopes to continue being a part of other community groups in Arizona working towards improvement of public health services and capacity building. So, Dr. Arredondo, take it away.
All right, thank you so much. And it's just been a pleasure to be involved with this group and with these people. That they're doing excellent work. And I'm probably going to skip ahead a lot in my slides, because I think a lot of what I talk about in outpatient-based treatment is very similar, at least in the policy standpoint, to what has already been discussed. I want to focus a little bit more about what we're seeing in the community as an outpatient or an office-based opiate treatment provider. Next slide. So I want to start off by discussing why this is so important. We know the numbers, and we talked about the numbers, and we're really just starting to understand what COVID has done to opiate use treatment. And there's been very little studies. There's some that are in places, as Beth mentioned earlier. There's been a couple of little small kind of non-generalizable studies that give us like sort of like a little picture of what's happening in different parts of the country. In one study, it looked at non-fatal overdoses in an emergency room in Virginia in 2019 and then 2020, and you see that the numbers have doubled in the same time period in 2 different years. Wainwright has a new study that came out in 2020 as well that kind of was a non-generalizable, not a national representative study, but it does look like a 4-month, 5-month basis in between in 2019 pre changes in DEA recommendations and also post, and it did look at the numbers of increases in fentanyl positives, almost doubled, as well as increase in methamphetamine positives, which we know that in combination with opiates leads to higher rates of overdoses. So that's the reason why we're doing this and why we have to look at our policies and have to look at how we're presenting treatment in order to improve on what we're seeing. Next slide. So as many people know, opiate-based opiate treatment was sort of brought about in order to reduce barriers to treatment. Previously and traditionally before 2000, opioid treatment were really based out of OTPs or NTPs. And with this, the passing of Data 2000, it did allow certain waivered physicians to be able to prescribe certain scheduled FDA medications and opiate treatment to an office-based setting in order to hopefully reduce stigma, hopefully reduce integration into primary care and to sort of normalize addiction treatment without that sort of regulatory burden. Next slide. However, there's been, as we mentioned before, sort of restrictions from the beginning. When we first started Opiate Data 2000, you really did see it was just for MDs. They had to follow a certain amount of certification. You started with 30, can only go up to 100. Next slide. And it really took a long time for that to change. And that's sort of something that I think we need to look at. Regulations for something as important as opiate use treatment shouldn't take this long to happen. So it wasn't until really 2016 that we started seeing increased allowances for numbers, the allowance for MPs, PAs to prescribe. And at first it was actually even restricted to only a certain amount of years. They have to do more training than the MDs do. And it actually took a little longer, next slide, for DOs to be able to prescribe. So there's been a lot of regulation and a lot of restriction based from the very beginning, and it's only been the last couple of years that we're really seeing these sort of swifter regulation changes. Next slide. But the nice thing about opiate-based opiate treatment programs is that it really does have less regulations. There's less regulations on take-homes, inductions. There's less restrictions on durations of use prior to inductions and this is primarily for buprenorphine. And while we still need to refer to psychosocial, behavioral health, and higher levels of care, it isn't mandatory that you provide those in your system, and you can do it from an earlier age. And also we have the other changes that prescriptions are reported to the PMP. So it is a less regulated way of providing care to the community. Next slide. And we talked a little bit about RyanHA, but obviously the RyanHA Act is the Online Pharmacy Consumer Protection Act of 2008 was regulated to put in place that you had to have at least one in-person exam for every 28 months. You couldn't induct any kind of scheduled medications, certain scheduled substances unless you had unless you saw this patient in person. And then next slide. And we did see that with the lifting of the RyanHA Act, that it did sort of lift some restrictions. So it allowed buprenorphine and other scheduled controlled substances to be done without a in-person. You could do telemedicine except for methadone, unfortunately. So we still have those restrictions that are limiting care for a certain section of population. Next slide. So I wanted to talk a little bit about what we're seeing in the community. I'm fortunate enough to work both in OT and also in an opiate treatment program at the tribe. And so I see sort of both sides of it. And what we're finding is that there are a lot of opportunities to what we're seeing now in terms of some of reduction in financial barriers, reduction in ability to do take homes for methadone, there are exceptions, the telemedicine expansion. But what we're really finding is that things that I think were always barriers and have been barriers for a very long time for a certain disenfranchised group of the community are being highlighted. We're seeing them more because more people are experiencing some. So with the service introduction to safety net facilities, you're finding people are having difficulty accessing care. The decrease of public transportation has made it very difficult for people to get to their opiate treatment programs, but as well as to go into pharmacies and pick up their medications. Financial stressors with people getting evicted, losing jobs. It's difficult for being able to pay for your medications in certain sectors and being able to pay for the appointments, especially in OBOT. There's been difficulty in access to technology. Telemedicine is great that we've been able to expand it and allow for people to get access to care in a different way. However, there are many sectors in the community, and we're seeing this a lot on the Pasco Yaqui tribe, that there is that not everybody has access to the type of technology needed to be able to provide those services and to attend those appointments. And so including even telephone or audio only appointments, and that some people don't have the minutes and don't have the phones, have not been able to pay services. So that makes it very difficult to be able to provide those services in all areas of the community. Other problems that we've been having are childcare concerns. Some people are able to get Wi-Fi, but the computers are being used or the phones are being used by their children at home, homeschooling. So they're unable to do their appointments. They're unable to leave their kids at home to go into the clinic to do their appointments. So they're kind of stuck in this situation where they're really unable to access their care, even though we have these expanded opportunities. And other things that I've noticed is our releases. We've had like increases of releases of incarcerations due to COVID-19, yet we've had not as much of the communication needed to get those people into treatment. And as many people know, after being released from incarceration is a really high risk factor and a risky time for people who are using opiates for overdoses. Next slide. So I really wanted to talk less so that we can have a conversation, be able to have a conversation, but I think that there's a couple of things that I really would like us to consider when we're looking at policy changes and what to do after COVID. I really think there needs to be an expansion of communication between levels of care. There's a lot of people that fall through the cracks. There's groups that are looking at sort of what are people who have passed away from opiate use disorder, where were the opportunities that were missed? And a lot of times we're finding that they did access, emergency rooms, they did access appointments, but yet there was no documentation of discussions about opiate use disorder and how to get them into treatment and what are their options. What about talking about initiation of treatment in different sort of areas, sort of like emergency room treatments. How do we get treatment into the places where people are accessing due to overdoses or other medical care? I think we need to consider permanent telemedicine coverage and use, but looking at ways to expand it in a way that's appropriate for all the communities, not just sort of those that have the ability to use telemedicine. I think that we have, there are many communities that don't have the access to the data and the monitoring that are needed. This is really prevalent in sort of American Indian tribes and tribes. We need to build capacity for them to be able to access their own data for their own communities so that they are able to make the changes and the regulatory improvements in their own community, but also for their clinical considerations. And then I think we need to talk about the data waiver and the limitations on the patient load. Why are we putting restrictions on a life-saving medication in many ways? As mentioned, I work both in El Rio and at the Pasco Yaqui tribe, and I see such a huge difference between how people are doing because of the lack of barriers in one or another. And just being able to, for instance, find people that can work at the tribe to provide the care, and it really limits how many people they can take in, and it's really unfortunate that we have to look at it this way, that we have these limitations on something that's so necessary. And I'll stop there so that we can have this conversation. I'll let Danielle speak as well. Thank you so much.
Thank you, Christina. Okay, last but certainly not least, we have Danielle Russell. Danielle holds a BS and an MS in Justice Studies from ASU. She is currently a PhD candidate at Arizona State University, where she hopes to expand on her past research and continue to study how the criminalization of substances used for personal pleasure has become a key issue and tool for social control, contributing to the ongoing legacy of racialized criminalization and mass incarceration in the US. Having personally experienced many of the harms that impact people who use illicit drugs, she is passionate about harm reduction and fighting back against the structures that impose these harms on the bodies of drug users. So welcome, Danielle.
Thank you for that introduction, Haley. I'll just add as well that I've been in and out, mostly in, of methadone replacement for about 10 years. I've been a client at 4 different clinics here in the Valley, and I've also courtesy dosed in multiple locations around the country, which has helped provide me a decent picture of what it's like to access methadone from like a consumer perspective. So over the course of these years, since I've been on methadone, I went back to school. I earned my associate's degree at Gateway Community College. I then transferred to ASU as a Barrett Honors student. I graduated with my BS and then my MS, both with honors, summa cum laude, and now I'm 2 years away from earning my doctoral degree. I couldn't have managed this level of stability and conformity without access to a legal replacement drug, which for me is methadone. So I'm gonna, oh, actually, are we on? Okay, can we go to the next slide? Yeah, thank you. So I'm gonna try to briefly go through these and discuss these 2 topics relevant to MOU regulations. Firstly, I'm going to describe my own experience and how I've perceived the changes in regulatory policies as a client during this pandemic. So I'm just going to emphasize as my own personal experience at one local clinic. And then I'll also kind of refer to some of my experiences pre-COVID at several other local methadone clinics here in the Valley. And then can we move to the next slide? Thank you. So like many people at the start of the pandemic, I read about the shift in federal regulations surrounding medicalized opiate replacement treatment. I was really hopeful at first. I'd read about like the potential for 2-week take homes, even for unstable clients, unstable. And like, you know, we'll touch on this patronizing and paternalistic nature of some of the language used maybe later. So I was excited because, you know, at the beginning of the pandemic, we're all kind of scared, wondering how things are going to turn out. If you're dependent on a medication for stability, that's also like an extra concern. So that's not what happened at my clinic. So the changes in protocol that are visible to me as a methadone consumer at my clinic were that, so unstable clients like myself were broken into 2 groups. So instead of coming in every day, we come in every other day. So instead of the possible 2 weeks of allowable take homes, we get 1 day. You know, which is still nice. We get a day, great. Oh, I think one of the issues too is that clinic staff consistently misappropriate the issues faced by like individual clients. You know, the person who has the most structural barriers to conformity with the regulatory policies and like project that across all clients. So notably these privileges, i.e. take homes, these strongly correlate to social privileges. A lot of the rules appear to specifically target unhoused clients and individuals dealing with cognitive challenges. So people who are having trouble remembering what day it is, you know, people that don't have the stability of a home, they're going to have a harder time to conform to callbacks, well, even like remembering the day. And I think, you know, with the pandemic, we're probably all kind of getting a little used to how just having disruptions in our schedules and lives can interfere with our ability to tell time. So, and I don't think this is a number that's really considered or easily quantified, but the number of people who could be benefiting from MOUD or MOOD, like there's too many regulatory barriers, so it prevents them from even getting into treatment. much less sustaining success in these programs. So then another point, the allowance for video and teleconferencing has been utilized at my clinic, but to allow providers and higher level staff to decrease their own risk of exposure and allow for them to responsibly quarantine in the safety of their homes while still requiring clients like myself to physically come in to scheduled appointments, sit in an empty room. So like you're ushered like by lower level staff who still have to come in physically, ushered into an empty room to speak to a computer. So that is how that has been implemented. Also, we've had like clients and staff are having their temperatures checked orally for the first couple months with like an oral thermometer. We finally got one of those infrared no contact thermometers, so that's been great. Oh yeah, and then we're also still being required to save and return our empty methadone bottles. You know, that we've taken home, we've handled them. We return these dirty bottles to staff, they're handling them. It just seems unhygienic. It makes me feel guilty, you know, like showing a lack of concern for staff safety. So, you know, like many of these COVID protocols that have been put in place at my clinic, the anti-diversion procedures, such as returning these empty bottles, is mostly performative. And again, they seem to exist to target and further marginalize clients, you know, those who are struggling with housing instability and like cognitive or other comorbid mental health issues. Oh, and then also there's been absolutely zero communication regarding protocol change. So aside from just being told that I would come in every other day, that's it. If I were to feel sick, or like if I actually tested positive for COVID, what do I do? Who knows? There's no communication. I have no idea. There's no transparency. I think there's like the most communication that's occurred is like a pamphlet on the wall, or not a pamphlet, like a flyer on the wall that says that Americans can get COVID. So useful information for sure. Americans are not impervious to COVID. So, and finally, the last change I've noted has been a reduction in the number of clients that are allowed in the waiting room. So, and we are requested to social distance inside the waiting room, but like not the smoking area or anywhere else. So, so overall, the impression I've been given is that these changes and their implementation are mostly utilized in consideration of the convenience of mid to upper level clinic staff, privileging their needs and safety. Again, this is one clinic. I know that's not across the board. Every clinic has different policies, and you know, there's no consistency. So it's just up to individual clinics to decide how they implement these things. And then if we can move to slide 4, please. So as I stated earlier, I've been to multiple clinics over a span of about a decade. You know, I feel like methadone, methadone is the most effective modality for like treatment modality for opiate dependency. My own experience supports this, you know, and that's what I believe. I think, as Nick pointed out at the beginning of his presentation, there's certainly room for improvement. And that does, you know, it's still a good thing. It just definitely has room for improvement. So I also think that if I had been able to enter treatment earlier, I would certainly have a lot less health issues than I do today. I didn't, and primarily one of those reasons, aside from stigma and just, I mean, I think a lot of like internalized stigma about it, but the regulatory barriers as well, they're so invasive and inhibitory towards like social thriving. It just seems like a last resort that you should only utilize if you're really desperate enough to put up with this kind of crap. I mean, because it's just, unless you're desperate, you're not going to do this. Because I mean, frankly, it's ridiculous. So, you know, clearly these regulatory measures keep people who want treatment from even seeking mood as a resource. What, like, just why would you put up with that? And I think even though other treatment measures, you know, you can even do research and see that they're less efficacious or whatever. But it's just the hope that you would not have to put up with this. So, you know, while some people accept the surveillance and they even appreciate it, many people would prefer solutions that don't require this level of hyper surveillance and intrusion into your life. So, you know, another clear reason why these regulations are also harmful is, you know, there's an environment of surveillance and heavy regulation, the therapeutic relationship non-existent. It cannot exist in the clinic setting. And I don't think I could describe anything that I've received at the clinic as therapeutic. I mean, that would be like a pretty kind way to describe what I've experienced, and generous. You know, because you just, if the whole function is to surveil you, why would you ever speak to someone about the things that are bothering you? You cannot, unless you literally wanted your life to be disrupted more. Like, you just can never approach your counselor or anyone at the clinic. Aside from the security guard, I think I have a better relationship with the security guard in my clinic. They should be giving them like a raise, definitely. But I think that, you know, a lot of people learn that, like, if you're in treatment, you quickly learn you can't speak to people, because that's it's going to increase the like the amount of drug testing. It's going to increase your callbacks. You lose privileges. So yeah, it's just it doesn't facilitate a good therapeutic environment. Also, the treatment goals at most of the clinics, you know, they center abstinence. Most of them are pre-typed out. I think I went to, so one clinic, the treatment goals were actually like you had a hand in creating them. You still better be able to articulate the abstinence is your goal. So like, if you can't, goodbye, good luck with something else. So yeah, you need to learn to, like, you just need to like parrot these, you know, therapy talk. You have to learn it, embrace it, repeat it. I think one clinic, I think the most interesting implementation I've seen of harm reduction was, so it said, we want to implement harm reduction here at the clinic. I was like, oh, this is really interesting. It's like quite progressive. I had to sign that I would practice safe sex daily, which seems a bit optimistic at my age, and just with the amount of time I've been in a relationship. But yeah, so that was their implementation of harm reduction, to practice safe sex daily. So I just had some notes in here about how failure to conform to rules and regulations results in increased surveillance. Therapy is utilized punitively. Urine screenings, counseling, other support resources, operate as punishments. Yeah, and then, you know, the clients that have the most barriers to conformity to clinic rules and regulations are the people who are dealing with the greatest amount of state violence in their lives. So it's like, it's unfortunate because, you know, you have a hard time recommending this as a treatment modality for people, even knowing as I do, that I think this is like the most effective treatment modality for somebody who has like opiate dependency. It's a hard sell. It's like a really hard sell. Even if I can say, look at what it, like, here's the things that I think it benefits for me, and I still can't sell this level of intrusion. So yeah, well, even stuff like, so I noted, you know, things like bringing a lockbox, for on the weekend, I get that extra dose. So, you know, being on time to appointments, daily dosing, returning the empty bottles, even the ability to regurgitate therapeutic ideologies compellingly. You know, if you can't communicate in a way that's valued, and like understood, and like at least compelling enough to not get kicked out, you know, you're gonna struggle with these things. So it's definitely constructed in a way that like blocks out a lot of people that could benefit. And then, yeah, I think personally, I think my conformity with clinic rules and regulations, this is a manifestation of my privilege. It's not manifestation of anything else. And I'm wrapping up here, the existing state and federal regulations support this merging of criminal justice and medicalized ideologies within the clinic setting. And as long as this is so, the clinics cannot continue to exist as a predominantly disciplinary mechanism. Because again, you have this, like the therapeutic relationship is fractured in this environment of mistrust and surveillance. And then finally, I'll just wrap this up, that reminding everyone, despite these insidious flaws, mood remains the best support for opiate dependent individuals that we have right now, but it could just be so much better. And changing these regulatory measures permanently would be such a great step in that direction, especially, you know, you have so much difference depending on what clinic you attend, how these these regulations are going to be implemented, it's frankly absurd. So that's pretty much what I have to say about that.
All right. That was incredible. So we are going to address some audience questions. Let me stop this share. Okay, I think that's better. So one of the first questions we received is on my phone. How can we implement a community health practice model in addiction medicine that allows providers to be mobile and truly meet patients where they are at? And I'll just add on to that question, specifically in the time of COVID. So any of our presenters have any thoughts?
Well, Haley, I mean, there's a lot of kind of innovation going on kind of in that space where, I mean, this is it's a hard nut to crack. You know, there are mobile methadone clinics that are currently, the DEA has not reapproved them, but they're working on the regulations. There's you all might have heard of the initiative by Blue Cross Blue Shield here. Obviously, the Sonoran Prevention Works is working with them on Mobilize AZ to try to get a mobile clinic that can do some amount of helping navigate people into treatment. You know, I know we've opened some clinics in some rural towns, and there's opportunities. It's hard to figure out because you have to circumnavigate all the regulatory barriers, but there's opportunities to like get pharmacies involved, get emergency departments involved. It's all very difficult, but there are a lot of cool, innovative things happening. It's just, you know, it's slow and it's kind of incremental.
I mean, I have to agree. I think the biggest thing that we have to look at is meeting patients where they are and having them come to us all the time for their treatment isn't working. And as you can hear from Danielle, it just isn't meeting patients where they really need their care. And that's, I mean, I'm a big proponent of trying to increase the amount of initiation of opiate use disorder treatment in patient hospitals, in emergency rooms, places where patients are going for care. Let's make it easy to get them started, and then work on our communication and initiating out into programs, but then also looking at how do we make it easier for them to be able to be home and work and do everything that they need to do.
Okay, so another question, and this is directed to Nick, but probably anybody could answer this. Is there any newer data around methadone dangers and such between 2010 to 2020? As the crisis increased, I imagine some things have changed.
Well, that's a long time frame. I think there was a study in 2014 that showed that methadone only makes up 1% of all prescribed opioids for pain, but accounts for 23% of all opioid overdoses from pain management. And so there's lots of research on, I mean, even in opioid treatment programs, methadone induction is dangerous. People, what makes, a lot of people don't understand this, so I'll try to explain it really quickly, but what makes methadone so effective at treating addiction is also what makes it incredibly deadly. It's got a slow onset, a long half-life, and so because of that, it doesn't flood someone's brains with like endorphins do. It doesn't flood someone's brain opioid receptors and give them that high, like fentanyl or fast-acting opioid like heroin does. It's a slow onset. What that means, though, is if a doctor doesn't know how to prescribe it, that a dose that is a stabilizing dose on day one, like 50 milligrams, let's say, day two, you give the person another 50 milligrams. They still have 25 milligrams from day one, so that's 75 in their system. By day 5, a dose that's stabilizing on day 1 is deadly on day 5. And so, methadone, what makes it incredibly effective is also what makes it incredibly dangerous to prescribers that don't know how to prescribe it.
But yet, Nick, what I find really interesting is that there isn't any regulation. You don't have to have a license. I mean, you have to work in an OTP, but you don't have to have any specific training to prescribe methadone. I mean, physicians, MPs can work there without having any kind of data waiver, but you do need that for buprenorphine, which I believe is much safer.
Yeah, that goes back to the stigma, but I will say many states are starting to take methadone off of their formulary for the treatment of pain. So there's so, I mean, this whole conversation, my biggest concern is with stigma. Everything we do is trying to break down stigma. Stigma is what stops people from getting into treatment. Stigma is what stops is what created the regulations. Stigma is what stops people, like Danielle discussed, from getting into treatment. Stigma. And so, the issue with buprenorphine is already 10 times more diverted than methadone. You talk to a lot of law enforcement, jails and prisons, they hate buprenorphine. And so it's one of those things that we do need to be responsible in how it's administered so it doesn't contribute to the stigma. That the stigma is still wrong. There's no getting around it. The stigma is wrong. The stigma is why we have the OTP regulations. But we have to be very, very intentional about how we expand access to care in a way that does not increase the amount of stigma. And really, we could go on and on about this. The war on drugs is the root cause of a lot of the stigma we have in this country. It's the reason we have this stigma against addiction. We have a stigma against MOUD because we have a stigma against addiction.
I mean, I guess just included with that stigma is this constant social obsession with controlling other people's bodies and what people do with their bodies, which is ultimately part of that stigma as well. I just want to add.
So we've got 5 minutes left and too many questions to be able to get to. So I'm just going to choose one last question. And I'd love it for all 4 of our panelists to try and answer. Based on what Danielle said, what can OBOTs and OTPs do to better align with supporting clients? Is there anything available within the current landscape for long-term change?
I mean, I think the big part of it is we do have things out there. I mean, we really this should be patient-led, patient-informed treatment. It really shouldn't be about us imposing rules and regulations. I mean, we need safety, and I understand that, but we also, I mean, I've seen it because I work in these places where you have to sign that you are going to absolutely not take these certain substances. You have to absolutely get a pregnancy test every month. I mean, it's just all these things that are done, and I understand from a public health problem and a medical plan why I would want to do some of these things, but I also think that if we impose it in a way from the beginning, it's not allowing people to be a part of their own recovery. It's basically imposing our timeline and definition of recovery on somebody else, and we have to figure out how to balance that. How do we balance safety and treatment, treatment safety and with, and what's needed for regulations with what actually needs to happen for people to build their own recovery.
I think too, and I'll only add a couple things here, is that, we have 2 different places where we need to be working, of course, socially, but the state policy arena can be often more stringent than even these crazy stringent federal policies. And so I think that's certainly something we want to watch out for as we think about how to create environments that will allow us to make innovations in treatment access, to test out different things, to have patient-driven models. We'd never put up with this with any other disease state. So I think it really matters that we're talking about the stigma that Nick was bringing up, and Christina and Danielle as well. So it's really that policy context. I mean, we've got the racism baked in, the penal baked in, and we have differences in the way we construct methadone versus buprenorphine and other treatment. But the core is that right now we have the Wild West as far as state statutory consideration is. Colleagues of mine and I presented to the Uniform Law Commission, which is a group of people that manage essentially advise governors of every state about what could be uniform across states. And the whole addiction treatment center regulations, regulatory, what we call architecture, is a mess. And states, of course, can decide what they do. But I think once we decide, together to set it open, less stringent, much more based on science, we need to gather some good evidence, especially about these temporary policies, so we can start to push that envelope. It will be better for everyone involved.
One quick comment on it. We talk a lot about the stigma against patients and against people who use drugs. But honestly, there's a stigma against the program providers, the practitioners in programs. I mean, even the fact that OBOTs, doctors in an OBOT, data waiver physicians can start a patient on buprenorphine via telemed, but a provider doing methadone cannot. That to me is really a stigma against the medical provider, against the prescriber. You could tell everything from a telemed that initial exam that you can from an in-person. I mean, with the technology that's available today, and it almost sends this message that, well, we don't really trust that you're capable of doing that. And so if the federal government wants to get involved in having some amount of influence, positive influence in this space, I personally think they'd be much better off figuring out how to align incentives with outcomes, things like that, rather than just trying to overregulate everything. You give discretion to programs. We have different clinics that do different things. Different clinics have different ways of setting up social distancing and stuff. Healthcare is geographically nuanced. What might work in Montana might not work in Phoenix, and vice versa. It's geographically nuanced. So saying there's federal regulations that everybody's got to do this, when a lot of times regulations are passed without doing pilots, without looking at the research and saying we're doing this based on the research, we're doing this because it makes sense to some legislator or whatever. I think the more autonomy and discretion that can be given to programs, the better. And to prevent bad actors, we should align outcome measures and stuff like that to how they're getting paid and stuff. I mean, there's a lot of things we could do besides just blanket regulations.
I guess I would just add too, speaking about autonomy, independent of federal regulations, like I said, I had one clinic that had client input on their treatment plans. That's one small step that clinics can take to include clients in their treatment process, because I would assert that most people who enter a methadone or buprenorphine program know what their goals are, and they are usually capable of articulating that. So allow them to do so. And be open to, it might be different than what you expect. Maybe it's not abstinence for everyone. Maybe that's not the central goal. Maybe it's getting a PhD.
Well, thank you so much to our panelists. This was such an important discussion, and I'm so glad that we were able to do this, specifically looking at the landscape here in Arizona. I also want to thank everybody who attended. This was a great turnout. We will have the whole presentation posted up on our website at the end of the week, so we'll email that out. Somebody asked if the slides will be shared. I'm not sure if everyone's okay with it, then yes, but that's something that we'll have to discuss. And I just want to thank our partners who allow us to do this really important work of giving people with substance use issues options for health. Those partners include Access, Mercy Care, Health Choice, Arizona Complete Health, Vitalist Health Foundation, and the AIDS United Foundation. And for those who are interested in getting more involved in conversations like this and work like this, I'd recommend the MAT Echo that happens every other Friday. That happens through Arizona State University in partnership with Blue Cross Blue Shield and probably some other organizations I'm not thinking of. Also, Dr. Meyerson, Southwest Recovery Alliance, and other partners are working to conduct more research around the regulations with a focus on patient experiences here in Arizona. So email Dr. Meyerson. I'm sure there are lots more I'm forgetting. I will email out some more resources and work groups to everybody who attended. So thank you all so much. And we hope to continue the conversation into 2021.